Welcome, folks. I think we're just going to get kicked off. We're really excited about this opportunity to present a kind of collaborative panel amongst kind of all of the movers and shakers and the folks that are working on trying to harmonize standards and harmonize implementation in their own countries, and talk to you a little bit about kind of how we're doing some comparison and contrast to how we're harmonizing amongst each other. So I figure we'll do a little bit of introductions first, and then we'll kick it off. I guess I can start. I'm the new kid on the block. My name's Sheridan Cook. I work particularly in the Canadian domain. So I'm a consultant with Accenture, but my primary focus is to help clients, particularly clients like Canada Health Infoway, HL7 Canada, to produce our kind of national implementation guides, our national implementation profiles, with a kind of lens of community building and trying to get folks excited to participate in standards development.
Hey, I'm Brett Marquard. I'm a consultant with Wave 1, and I grew up in the EHR implementation space, doing version 2 and CDA interfaces, and found my way to standards, which all of you should come join us after. We have DevDays here, but HL7 community later, or your local affiliate. But I've been involved with kind of the beginning of the US, I guess the original US core development back in 2015. And have been around with a team of us. It's not just me. There's a team of us who do the annual updates, and look forward to sharing with it today.
Thanks, Brett. Hi, I'm Danielle Tavares-Rixon. I'm from Australia. I'm the FHIR lead for Sparked, which is our national FHIR accelerator that kicked off 2 years ago. Well, actually, no, hang on. It's a 2-year program, so it's been a little over a year now. I'm getting ahead of myself. I've been working in Australia in digital health standards for maybe about 15 years now, and have been involved in FHIR implementation and standardization in Australia since, well, we started with it, which was, I think, really 2015 when we started looking at that in Australia.
So I think Brett might have stolen the thunder of our learning objectives, which is I think our underlying goal is to make folks excited about participating in standards and to build confidence in the national programs that are operating in markets where you may be implementing, that we are working to consolidate your experiences, your feedback, your kind of reactions to the expectations, and kind of incorporating them into some of our other national communities that are doing the same from an information modeling perspective. We want to give you some insights into kind of what the role is of some of the national core communities within kind of convening, I would say, feedback around particularly some of our new and emerging concepts. So we've done quite a lot of work, I think, across our national cores over the last year on kind of exploring some of the things that are coming down from international guides, like the gender harmonization projects, and trying to understand the role of your national core in being a conduit between those things. And I think the last piece we're wanting to kind of have you walk away from is, how do I engage? How do I get excited about actually participating and doing some of the activities that we'll talk about with you folks today?
I get so excited about inviting people in, right? It's good. We need your input. So the first part is what is a core data for interoperability? And you're going to get slightly different flavors because in different domains, we've taken it to different levels. And in the US domain, we consider it to be standards agnostic. And it's actually fairly high level if you were to look at the US CDI. So it'll say medications, and it'll give a few examples of route, dose, but it's not super detailed. It doesn't go down to data type, the specific value you need to include in a lab observation. But it sets the floor. So the one thing that is consistent for all of us is that it sets the floor for interoperability, that we want to be consistent. So if you're going to do labs across your variety of use cases, here is how you're going to do it. But that's done in the actual IG itself. So, for us, in the US, we have the Office of National Coordinator who provides an annual update to us. They do a draft in January. So if you're in a different domain and you're looking at developing a process, we very much agree that having a draft process where you propose to a community and then have feedback and then final is a very good thing. So not just at the standards level, but at kind of the policy level. So in the US, it's January is the draft, finals to July. There's lots of, sometimes I get hundreds and hundreds of, maybe sometimes even thousands of comments on that. And then after that, there's a standard cycle where we build our US core. So there's an Australian core, Canadian core, there's others around the world. But then we build that standard off of what the kind of data policy is. And for us, it takes us some time. And I think the Australians are quite quick. There's a couple, no, you'll say. But it takes us like 9 months after the kind of policy is settled to actually develop the standard. And we do some solid testing. But then that's what we call our kind of core profiles, is building that standard. And for folks who, there is a, we're in the US here, so there was a US core, US CDI talk earlier this week. And the analogy I use is like, I feel like we're playing a game of leapfrog, where like the government jumps over the standard, and then the standard has to look at what they've added, and the standard jumps over the policy, and we're kind of constantly in this game, like jumping over each other to provide that guidance to the implementation community.
So one of the things we wanted to talk about is the fact that the work on CDIs and the work on cores tends to sit within a larger framework and a set of requirements. This slide is particular to AU CDI, AU core, and when I say AU, that's our shorthand for Australia because it's quite a long word. And for all of our work, and especially in Australia, but still for all of our work, that ends up surfacing and taking in a number of requirements across digital health initiatives and looking at things like servicing clinical decision support, servicing aggregation. It's all also, obviously, we're in it to have better health outcomes. So it's about ensuring we have better data to service like our primary care, provision of care. And that sits within the broader initiatives and frameworks within the government and what else is going on in order to drive those data models, which then drives in the data exchange, basically, what we're doing with our RESTful APIs to talk about surfacing those particular CDI elements so that people can have access to them when they need to. And that then goes on and drives those additional initiatives and sits within larger frameworks that we're all working within of international standards and gender harmony adoption to drive. Well, all of us kind of moving forwards together is really what we're hoping to do, which is one of the reasons we have this panel today, because we're all committed to having better health outcomes within our nations and making sure we leverage each of the advantages and lessons that we've all undertaken within our different jurisdictions.
So Danielle, I really like your slide because I think it makes it feel like possible, it makes it feel consumable, but in reality, like there's so much work that goes into like the bidirectional feeds, not just between like the downstream implementation guides, but also the actual kind of upstream artifacts. So whether or not, you're primarily oriented around a CDI, or you also have artifacts in your country that's oriented around, what are the logical data models? What is the data content standard? What are the surrounding requirements? And I think that the thing that makes this a really powerful process is that it isn't necessarily like unidirectional, and that we can collate requirements and collate expectations and feedback from any point in the channel upwards to ensure that we kind of stay aligned over time. But it takes a lot of effort, right? I mean, we've certainly been like putting a ton of time over the last year, at least when we think about kind of our relationship to the core, to a broader set of kind of requirements and artifacts, the processes to support that. So when I came here and I started chatting with Danielle and Brett about this kind of leapfrog analogy, I compared that to kind of our process in Canada of, working side by side with the folks that are developing some of these kind of logical data models and information models, and doing that in parallel, actually, and trialing this process where, we were exposing, an early maturity version of our core profiles along early maturity versions of our information models and early maturity versions of kind of architectural descriptions and reference architecture. And I would say like this has been a learning process for us, but for the most part, it's provided us insights into what are the ways that we can actually kind of amplify some of the feedback that we're getting from our community. Maybe that you're a FHIR implementer and you work with many of the end users, and you can kind of provide perspectives from the clinician, or you can provide perspectives from your vendors. Providing a process where we can actually kind of take that feedback and ensure it makes its way into the kind of right artifact has been a huge focus of us in the last year as we take on what I would say is like our first year really developing towards eventually a CDI and core profiles that will be kind of one-to-one related to them. Maybe that sounds crazy to you guys, but.
Yeah, no. So what's the relationship between these things? So in the U.S. market, it's the Office of National. I feel very. I don't know. Look, there's ONCs there. They're everywhere. It's good. I feel very fortunate in that there is a regulatory body that is taking feedback from a huge array of constituents, like professional societies. You know, the cardiology has their very specific elements. You know, and every kind of subdomain has the things they want standardized, and they should be able to have those things standardized. But someone needs to prioritize what we're going to work on, and also look like what is most useful across all the use cases. And so I feel very fortunate in the U.S. We have the ONC that's setting that, and then it's very high level, and then the kind of market, and this is kind of a very maybe U.S.-centric thing, is that the market of vendors, clinicians then come together around the direction the ONC has set to then define discreetly how we're going to tackle that problem. So when they say lab results, they say lab results. They don't tell us they do tell us we have to use LOINC, which is a good thing, so that's new. But they don't have to tell us like the value data types for lab. Like we can duke that out together and say, hey, you need to have codable concepts and here are the things you need to do. And so we do that through the standards process, which isn't necessarily consistent across. Obviously, that's how we've grown up doing it. It's worked. It doesn't mean there aren't other approaches that could work well and take different approaches, but our core tends to be very high level. Sorry, not our core. Our CDI is very high level. Our core is very detailed for implementation.
Yes.
And we do it differently again in Australia. We have a different focus. I think all our cores are fairly similar in what they're trying to achieve about a RESTful API that services some core digital health and administrative information. But the approach taken by our CDIs across 3 different jurisdictions is different. So in Australia, our AU CDI is about representing and driving clinically led sort of data-driven standards. So it represents clinical priorities. So its scope is those things that are very high priority for our clinical community. So it doesn't include demographics, it doesn't include administrative, technical, billing, those things. That's devolved entirely to the technical group to build those out in the core and determine how do we exchange the things that are of clinical priority, basically. And one of the other things that I think is quite different is that AU CDI is, I'll call it, it's forward thinking. So it is in a lot of respects future driven. So it represents clinical priorities. It's undertaken, both of them are actually undertaken through Sparked, our FHIR accelerator, under 2 separate groups. One is the clinical design group, and that has a much higher percentage of things like peak bodies, clinicians, healthcare providers, and so forth. And then we have our technical design group, like our work group that does the core, and that has a much higher percentage of like our vendor community. And in the clinical design group, that is the remit and the focus to represent where we want to go with clinical data in Australia. And it is where we want to go. It's not always what's in systems now. So some of those things are in there and they're being designed intentionally known that that's not something we can actually match that year in the core release, because that is going to actually require a change and a step up from a whole bunch of clinical information systems. But it provides that future roadmap of what is being deemed as the clinical priority and how it gets modelled, which I guess brings us to quite a difference with US CDI, that AU CDI is defined as a logical data model, quite a detailed one. So it has like data types, it has your terminology, it has cardinality, it has future considerations, use, misuse, but it's not modelling a RESTful API. What it's modelling is a health record, like a clinician's set of priorities when they go and view a health record. These are the things that are important to them to see. And then in the technical side, we come together and go, well, how do we support the exchange of said elements in a RESTful API? So therefore, we often have those, it's different cardinalities, and we interpret that through what can we achieve and what do we agree that we can step up to and deliver now, and then we roadmap out the things that are future thinking into like a future version. How and when will we get there?
I'm just going to draw some parallels real quick, because I think one of the amazing things about maybe Canadian culture or Canadian identity is like looking to your peers and seeing kind of what's working, what's not. And I would actually say there's quite a lot of parallels in some of the initiatives. Like in Canada, we have our core, which is kind of, as Brett described, it's the kind of FHIR profiles for RESTful exchange that kind of speak to the requirements, the clinical, the technical, the implementation, functional. And those are developed by an organization called Canada Health InfoWay through the standards development process. We also have an organization that we work kind of hand in hand with called the Canadian Institute for Health Information. And they have, I think, taken, a lot of parallels from the work in the US and from Australia in saying, I think we actually can maybe escalate some of this development if we are looking at introducing data types and introducing kind of expectations for terminology up front to make things a little bit easier downstream when we actually go to profile, so that there might be actually less room for interpretation. So like I sat in on one of the conversations yesterday around like what happened over time as expectations for data types were applied in some of like the US markets, and what that meant for implementers that might have coded against period and then had to switch to data, I think it was date time. And I think that like by having some upstream artifacts that are like making some of those stances, I think the impact is that kind of our downstream developers are actually able to kind of like harmonize around an approach, and we're actually taking some of the burden off of our client applications to like query a bunch of different ways because we have been explicit. So I think that's one of the things that I think is very common between our two approaches. While we are still very, very, very early in our CDI, I think our framework takes that stance very seriously. Stakeholders. I can start if you guys want me. Okay. So I think this is a really interesting diagram. It was something that came out of the last working group meeting.
Minnesota interesting?
No, it was real interesting. I don't know.
Minnesota too, so I can say that. All right, if you hear interesting, yeah, you know.
And that's a joke from Brett's last USCDI CA Argonaut. Yeah. So I think one of the interesting kind of insights I've had working in standards development communities over the last 4 years is that, when we are focusing on kind of FHIR implementation and FHIR profiles, we tend to draw a particular set of stakeholders time and time again. And in projects that are very early in their implementation, like I know our FHIR base, our FHIR core, we have seen tremendous amount of stakeholder engagement, particularly in the kind of vendor space, and particularly in the in Canada, we have provinces and territories, and because of the way our healthcare is delivered, those provinces and territories sometimes operate kind of centralized assets. So they might have a clinical data repository. And we've been very lucky to have stakeholders from those kind of clinical, business, operational teams that are influencing kind of what goes in on that left side of the field. Like, how will this actually get implemented in our APIs? Because they're some of our earliest FHIR implementers in Canada. And we've also been very fortunate that those kind of unicorns of kind of end user perspectives are also significant contributors in some of the upstream artifacts that come out of our Pan-Canadian Health Data Content Framework. But these are like very, very small teams, right? So they're like heavy hitters, but we hear very often, like, I'm contributing wherever I can and I'm trying to keep these things aligned, but I'm only a team of 2 to 4 people. And so I think that like we've seen this organic alignment because of that over the last year, because the sweat and the tears that are going in from those types of stakeholders alongside, the professional organizations and the clinicians and the folks from academia and the vendors that are contributing into like our architectural artifacts. But at the end of the day, I think probably in the next year, we're going to start to see a little bit more segmentation, because that is just a practical response to, trying to ensure that you're putting feedback into the artifact that's going to be closest to the work that you're doing. And so I think we will maybe start to see more segmentation because of that. But we definitely share between, our Pan-Canadian Health Data Content Framework and our CA core, a lot of the kind of bandwidth of some of our earliest implementers.
It's interesting when you talk about like the stakeholders and where they engage. I think for the US market, the kind of professional societies seem to do a stronger engagement at the policy level. I see the number of feedback and comments from them to be much higher at the HL7 standards FHIR development process. I don't think we scare them away, but it may not be as clear in terms of how to engage at that level. I do think, it's interesting, Danielle's comment about like being forward-looking. I think US CDI goes back and forth about how forward-looking it is. The kind of original foundation of US Core when it was born was we wanted to represent what systems actually captured and were ready to exchange. And I think we all want to make things that are real and useful. And I think there's policy, like the stakeholders are pushing for new things. And sometimes that's really good. Like social determinants of health data, equity in the US is not something, we needed to kind of get a nudge to capture that. But there's always this boundary of like, I find, I don't know about your stakeholders, but ours sometimes like try to hit us in multiple spots, be like, hey, can you add this thing? And they talk to the policy folks, and then they like come talk to us, and they talk to us. And I think some of them learn like we're all talking to each other. And so when we're like, hey, this person like won't stop calling me, like, can we like have a conversation with them? So it's just one conversation. So some stakeholders are very persistent, but we do get a varieties of like clinicians, technical folks, and I say some vendors are actually engaging all up and down the line too.
So in Australia, where we have a clinical design group that's working through AUCDI and a technical design group that's working through Core, and that's under HL7, so it follows those processes. Both groups have over 400 members. Not to say that every meeting has 400 people, thankfully, because getting consensus amongst that would be, that would take longer than a usual work group meeting. And they have the same types of stakeholders, actually. So we have consumer advocates, health professionals, which we classify as including like peak bodies, individual practitioners, healthcare delivering organisations. We have vendors, we have government, we have universities. And across both groups, we have something like, I looked up the stats last night so I could let everybody know. We have about 2% consumer advocates in both groups, so that's about 8-9 people. Some of whom turn up to every meeting, which is fantastic, and they're providing that input in. Government, we've got 25% across the groups, and that is at federal and state level, so that's both agencies and the actual government itself, and they are very committed and engaged. They are at every single meeting, they're commenting on everything, it's fantastic. And then where we really, I guess, see the difference between the clinical group and the vendor group is, I guess, they swap between which is the majority. So you have about 40% of health professionals in the clinical design group, which drops to about 20 in the technical, and then vice versa. And they engage in different ways. So the thing about AUCDI is to reflect the clinical priorities. So that is very much the clinician-driven, clinician setting what is the kind of data that is relevant to the clinical workflows, and so a lot of that is driven from that perspective. And what the vendors do when they engage there is provide, I think that, so I'm from the technical side, provide the necessary context to those conversations to say, what does that look like in systems now? Like, where are we? Is this an achievable thing? Is this something that we're actually going to have to drive massive change? And already sort of forecasting that what you think you're asking for that might be something simple is actually not, or maybe it actually is. And then we see the other perspective in the technical group where we have a massively engaged vendor community, which is fantastic, and we're going into that detail of how does it work. And we have clinical representatives at every meeting. They change who it is, who are providing that context then to give us the perspective on, yes, but how relevant is this terminology to you? How are you actually using that piece of data in your particular workflow, and how does that happen so that when we're making the decisions for our RESTful API, that it's at least guided or informed by clinical practice? So that seems to be working for us so far. I mean, admittedly, we're in R1, so, it's working so far, which is pretty fantastic. I guess the other thing I wanted to comment on is we have fantastic engagement from the groups that are there, but when we go out for comment, which is designed to do wider community, that's also happening. So we went out for comment for AUCDI, we've been out for comment for AU Core, and we got about 50% of respondents who weren't members of the group, which is exactly what we wanted, which was fantastic. And some international groups who were commenting on those. Again, that's what we're interested in. You don't have to be Australian to, come in and have a look at that content and provide some feedback on where you think that direction is going.
Actually, I might put this one, because I think one of the things that we've talked about in terms of like ways that you might have upstream or influenced upstream artifacts, we've talked quite a bit about like gender harmony and representation there. But I don't know if you want to share a little bit about that.
Yeah, I think this is going to be more, we're going to probably end up doing less of this in Australia because of how we've scoped and defined our CDI, that it has to reflect clinical priorities. And the fact that we expect that there will be a wider scope of elements defined in core to satisfy our minimum requirements for a safe exchange of data. And plus we're already in R1, so we don't yet have any of the legislative requirements or things where people are trying to drive things into core. To be honest, I don't think we're really going to have the situation where people are trying to change AUCDI by getting changes into core. Part of that is because we are asking people, all people, be they vendors, consumer advocates, to be engaging directly with AUCDI. And we have 60% of our members are across both groups. And they engage and they're commenting on and driving those changes in the CDI itself. And that's what we want. And the core needs to reflect how do we support and define those clinical priorities. Admittedly, there will be times, and we're looking at that, where there are some elements that aren't just administrative or billing or those sorts of things that are clinical, where from our vendor community, we have gone, look, this is a really high priority for us to standardise and have a national exchange on how do we do that, because it's incredibly high traffic. And sometimes we're going to be doing that well in advance of AUCDI. Now, AUCDI might never actually put that element in, because even if it's clinical, it just might not be a high priority. They just will never end up getting to it. Or maybe it'll be in release 30 or something. So it's so far away it doesn't matter. And then there are some times where we actually expect that they will get to it, but they're going to forecast. So we've got a case now of pregnancy status, which we kind of expected to come into AUCDI pretty early. And what that looks like in most systems in current data is like a yes, no, or like a checkbox or a Boolean field. But what had come out of the clinical design group was that they felt that was not at all what was acceptable, and it needed to have much more complex and future-driven modelling. So we know that when they get to it, it won't represent what current data is, but there's still a strong need amongst our vendor community to be able to exchange that. So we need to look then at how the relationship between core and CDI works, where we're going to be defining how do we safely exchange data we need now, while expecting that CDI will come out with something more complex that's the roadmap, and then building our way to that. It's not an R1 problem, but it's probably an R2 problem.
Yeah, and maybe I should have framed this a little bit. How many people, when I say upstream artifacts, are thinking only within a given nation? When I'm saying upstream, I'm only talking about the CDI. Okay, because I also think about upstream artifacts as part of that virtuous standard cycle. How am I influencing the types of recommendations and expectations in international guides like Gender Harmony IG, right? So I think one of the things that both I think we've shared some experience on, and from our experience in Canada trying to represent our constituents' need for recorded sex and gender, that those conversations were starting to happen through the core around how does this actually kind of get modeled? We're interested in socializing it, but we're not to the point where it's in the CDI yet. But to be honest, it's not usable in the extension registry today. So one of the ways that kind of as a FHIR community, we've been able to be a conduit is to actually be that kind of go-between with kind of our affiliate with HL7 International to say, we actually need this changed in the extension registry pronto. This is what our implementers on the ground, the people closest to this work, are saying about this, and we need to see this change. And sometimes they need like a babysitter to get it over the line. So that was like at least our experience in like upstream artifacts like the extension registry, upstream artifacts like, package registry actually working the right way. So yeah, I should have been maybe a little bit more fair in framing that. This next one, do you want to go?
Yeah, go ahead, go ahead.
Okay, I'll just frame it a little bit because I think this is something that I often hear. It's just like, this is a really powerful community. I think Brett kind of hinted at it, which is like, how do you ensure that folks feel like by incorporating something into feedback for the core, like we're not maybe kind of slipping it into some of the underlying requirements. And I would say like, at the end of the day, the piece that I look at with this question is like the backdoor piece. And I think if our programs are really good at ensuring that, if we hear a requirement from the community, like for us, I think allergy intolerance verification status was one. We had folks that were saying, this is really important. This is important to my clinical practice. And like for us, we made the decision because we have a one-to-one relationship between our upstream artifacts within Canada and our core. We're going to take the time with that team and ensure that they hear this feedback and we are the conduit for that. And I think that's what makes it like a change for improved clinical practice without having to feel like it's a backdoor change, because there's this ability for like the checks and balances to occur at the right spaces for those conversations to occur with the clinical requirements are developed.
Yeah, and when we say backdoor change here, the idea that in the standard you've introduced some new requirement that then forces the applications to make some update to support the standard. And that's something that we try to avoid to do, because the idea is that there's a policy from the kind of US CDI level, or we're building on an existing capability. I think, do you want to move to questions? Or all right, I saw a question go up, so ready to rock. All right, so we're going to use the mic for this. You'll take this, and then we're going to use this.
Yeah, exactly. So who's first?
I think I saw Isaac first, and then
Isaac first?
this row.
Hey, thanks. Thank you. Really fascinating session. I appreciate the panel. I've got a number of questions, but I'll take turns with you and everybody else. I'm gonna start with the one that the topic you just left. So, wouldn't it be better for interoperability overall for there to be no national cores and instead to have a collaborative like standards development process that's managed by a group like the HL7 International Council? Right now, the work to find and advocate against and solve the incompatibilities and differences that you create rolls downhill onto the shoulders of implementers. So overall, like, wouldn't it just make a lot more sense for you or maybe the CDI authors in your locales to agree or at least accommodate one another's priorities? Mm-hmm. For example, like International Council or like GDHP as a convening body. So assuming that's practically impossible because of sovereignty, could your processes consider universal realm interoperability specs as like a floor of the floor? So for example, GDHP's work on IPS as a universal realm spec. So right now we're seeing, PSCA in Canada is profiling. I assume Australia is going to profile IPS like with an Australian version of IPS. We haven't seen that in the US yet because the US uses CDA.
Does everybody know what IPS is?
It's a great example of a universal realm spec that's, I think, supported. International Patient Summary. Thanks, Rob. Okay, and then, and so maybe could different locales like represent, promote, nominate like those, hopefully well accepted universal realm specs as that floor to interoperability. And then grow from there, because all you guys are growing from there right now, but you're not nominating that universal realm spec other than as an upstream artifact that may or may not filter downstream all the way.
Thank you.
I might tackle that first because actually, we've been very, very active in our, I would say like, in trying to ensure that we are tapping into channels like the International Patient Summary and International Patient Access working groups. We are connecting and actually working with the International Council and GDHP in the space of patient summary to ensure that as we implement IPS in Canada, like our findings, right, what our folks on the ground are actually expressing are actually flowing the way backwards. So I would say that like all of the pieces that you mentioned of like, should we be doing collaboration through an international channel? The answer is yes. I think there's also a practical component to this, which is if I go and I work on patient summary in Canada and I am ensuring that I'm working with Rob and I do patient summary or patient access in Canada and I work with Isaac, if there's another group that's working on e-referral, and there's another group that's working on service directory in Canada, how do I ensure that while we all might be following the virtuous cycles at a domain perspective, that what I get at the end of the day when I say, okay, vendors, I'd like to implement this set of elements so I can support a number of use cases, becomes really challenging, I think, if you don't have that core framework as a foundational component. And so I think the core is maybe more acting as like a convener role while we're stepping into and engaging in those spaces internationally around domains. But there doesn't, I mean, to my knowledge, is there like an international core set of requirements? Across, like use case agnostic?
That's the FHIR spec.
Well, yeah.
Yeah. I mean, Isaac, I think about this just at some point a group has to make a decision, and like we don't all agree, right? And so to me, like the idea that like there's this nice thread of like, oh, if you make it, you want to make sure everyone has an opportunity to comment, but there's different, and I think about where we are, and I suspect in Australia and Canada, sometimes the policy folks have specific things in mind they want to accomplish that may be in conflict with what the vendors want, or maybe the international community wants. And so they have a right over their jurisdiction to do that. And so we can say no, but I don't know, regulators regulate, right? That's like one of my things in my head. So, but I agree, the more we can push up to the international level, the more we can kind of standardize across and create that floor then we all build on is a real positive thing.
Let's take the next question.
I was thinking in a similar vein to Isaac, but let's scope it down more to a technical level. Let's say regulators happen to have agreed on a few things across the 3 countries that this needs to be modeled. Do you seek alignment on the technical level that you all model it in the same way so that implementers like Isaac, they don't have to do the same thing in 3 different ways? And not just modeling, but also the exchange patterns, the RESTful patterns of exchanging documents back and forth. Those can quite differ.
So, I mean, yes, we do. I think I think we're all acting as good citizens as through our affiliate under the expectation we are actually trying to harmonise at an international level. We absolutely pay a lot of attention to other national cores and looking to leverage and get agreements, and we go, we'll take the pregnancy status example again. Is that already in US core? Is that already in IPS? What are those codes? How does that work? How can we leverage? And is there any possible reason? And then is there any possible reason we wouldn't use that? I guess, which is very rare, but occasionally there's some very legitimate jurisdictional requirements that mean you can't adopt that. But by and large, we're all looking to leverage those. I would like to see personally the affiliates have in their governance somewhere, all of them, something about the fact that they intentionally intend to and require their projects to harmonise internationally. We've taken a lot of good steps towards that in Australia with how we've localised our Australian FHIR community process, and we've got a coordination committee, and that is one of their actual requirements, and that's flowed into our work group charters. So if anyone ever comes, and you're welcome to, because they're all open and they're all available on HL7, if you come to any of our technical design groups and there's a new thing, we're going, well, this is the concept, and we're going to walk through what it looks like in IPA, IPS, US core, and wherever else we find that, and go, here's our proposal, understanding what else has already been implemented. And I think that's probably similar for both of you as well.
Thank you.
So Danielle, I'm going to pick on you a little, but it's not you. It's just what you said. And you were talking about stakeholders, and you said something that, I mean, that was almost funny to me. You said, well, you have 2% patients
Yeah.
consumers.
Consumer advocates.
And 25% government, which is like, and the government is for who? So the problem, I think, about getting people out that are really represent the diversity of consumer opinion is that they're not paid to come out. Their time is not paid. They're not compensated. And also, lots of times, they're sick or taking care of someone. So somehow, I think we as a community need to figure out how we need to see the incredible value there and find a way, because medical research has figured this out better. We compensate people to take a survey, or we let the person with the horrible cancer show up at the cancer meeting with the doctors, right? Compensating patients a little bit for their time, and also for expenses and where they're going. Somehow we've got to figure this out better.
Yep, absolutely agree. It is something we are trying to work on intentionally to get more consumer advocates involved. There is some limited, I don't know what the word is, where we are funding some consumer advocates to come to the events and to be like co-leads of the clinical design group and come and participate. I think we need to work out how to do more. It is something we are continuing to work on. I've not seen anyone really solve that in the standard space yet, but yeah, 100% agree with you.
Thank you.
This one's a more practical question regarding the sort of relationship between the core and the CDI folks. Probably more for the CDI folks that are more conceptual. So maybe Australia's in a different situation here. So here's the example to frame the question. Records of administering medications, right? So medication administration in FHIR speak. In US CDI, there's been for years like multiple federal agencies, multiple associations, et cetera, public health folks, et cetera, saying, this should be standardized too. And is it possible, and I hadn't realized this myself, that from an ONC, as the US CDI folks, from their perspective, they've covered the general concept of medication, and patient, right? Request, all of that sort of just under the general conceptual umbrella. So is it possible we're asking the wrong people to consider, because as it stands, records of administration of medications are unstandardized, effectively. So is it possible that's when you have the conversation go to the core folks as opposed to the CDI folks?
So in the way the U.S. looks at U.S. CDI, I know some of you are familiar, some are not. We do have these levels of how mature a data element is, and so I think for that particular thing, I think it's really because you want to adopt something, you want to create an interoperability specification on things that are well understood and accepted across a broad variety of institutions and vendors, and so clearly medication administration is understood within those systems. How well that's exchanged, I think. There could be some debate there, but I think the biggest thing is to push up that maturity, push up where you can, and I think that probably is one that is at the kind of national core level to then push it back down. We have talked about a lot. We do have active medications, but you're right. The explicit act of administration is not something that is included in our core today.
I think final question.
My question is the opposite of Virginia's. In Canada, we have the provincial and territory health systems. How do we get engagement from the provinces? How do we get buy-in from everybody? How do we get, a representative from each jurisdiction on those calls?
So the short answer is it's a lot of people engagement, a lot of people moving. And working in the Canadian space and seeing kind of the levels of, I would say the levels of leadership engaged in this space, I think is solely due, I shouldn't say solely, it is phenomenally due to the incredible work by Canada Health Info and the Canadian Institute for Health Information that are actually going to folks at the kind of leadership level and saying, can you participate in our shared governance? Do you agree that this is how we prioritize certain use cases in our roadmap? Will you commit to not only showing up and rolling those out and implementing them in your programs, but also coming to the table and providing feedback. At the other side of things, we've done an incredible kind of community building exercise in our national base, where we've asked explicitly our kind of jurisdictional technical leads, the folks that are like working in databases and that are working in the initial rollouts in FHIR, we have a call every Friday. We're going to discuss profiling for the national base. We will record all our videos. We'll talk through challenges you might be experiencing. You can share what some of the rollouts in your jurisdictions look like. And I think we've done this like grassroots growth that has further insulated within those organizations the intent to continue participating and maintaining it as like a collaboratively bought, collaboratively owned set of artifacts. So I don't know, it's like top level, bottom level approach.
Thank you, Sheridan. A final comment by Isaac, and then we'll head over to lunch.
I'm really worried about FHIR fragmentation, so that's why I give you guys a really hard time. But the fact of the matter is that you and the locales you're representing are leading, I think, globally, not only the fact that you're here, but the fact that you're up on stage. So I just want to say, like, congratulations and thank you for all the work you do, and great work.
Thank you very much, everyone.